conclude patients with PFBC have a broad range of symptoms, but evidence-based treatment is currently not available. And attendees promises to be an effective treatment, and participants for the calcifate study are very urgently needed to actually prove that this is a good treatment. Last one, please. So thank you very much for your attention.
Fabulous. Thank you for that. And I know that there will be many questions, and we've had a few in the chat. I think what was really nice is just seeing those linkages between what Amit was discussing earlier, and then really now, a few years after first having some of these conversations initially, was it's now that there's a study happening and we can see progress being made in the field of potential treatments and for the future of better managing the condition. So I'll start off with one of the questions that's been submitted to us, and I'll let you decide who wants to go first with this. Here, there's a question around future treatments. So kind of what happens after the calcifate study? Are there any next steps thinking about what happens? How might something become available more broadly?
Dineke, are you happy to take that? So in terms of
Yes.
what you're asking is how will this become available for general use?
Yeah, for general use. Yeah, thank you.
Yeah, the first step, of course, will be that the trial will be positive so that we can prove that attendees is working. And in our hospital, we already have it available for patients with PXE in the Netherlands. So if it's working, then we can try to get it available for all the patients in the Netherlands. And if we want to get it available in Europe, then we have to get registration in Europe. And that's quite a difficult step to take. But that's the next thing that we have to work together on, that it will become available for all patients across Europe, because there are not only patients in the Netherlands, but all across the world, of course. But that's a difficult step, but we will work on that, of course, to make it available for the patients.
Yeah,
I'll just add to that, Adam, that this is a repurposed drug. So in some ways, when you come up with the pharmaceutical company comes up with a new drug that is completely new, there's lots of requirements for safety, etc., and you have to go through several stages. The study is a repurposing study, so it might be actually easier with the paperwork when it comes to, for example, NICE approvals compared to like FDA approvals and NICE approvals, compared to when you're starting afresh with a new drug that has no safety evidence, because attendees is already used for osteoporosis in clinical practice, so it's already available, it's out there. And what we would be asking for is an off-label use or a repurposing approval.
Thank you. Here, I think this might be a question from a clinician. This is there a network of neurologists that can best support my patients?
So I can take that. If it's in UK, yes. If it is in Netherlands, yes. If it's in Italy, we've got some friends, and in there's some other friends that we have in France as well. But depends on where they are. So if they are in the UK, I think we do offer, as I said, we've got a rare movement disorder service. We're still in development, and I can see from the list of attendees, I think Dr. Kolipara is here as well. So he's one of the people who help us with this clinic. So yes, in UK, yes, in some other countries, but it's very variable, and unfortunately, we have no control on how the world works. If I had a choice, I would have a specialist clinic dedicated to FARs in every city in the world, but that's not the case at the moment.
Thank you. So here's another question around MRI versus CT scan. Which is best to see calcification and why?
Okay, can I take that, Dineke?
Of course.
So CT scan is better easier, cheaper, but it involves radiation. MRI is more expensive, theoretically, longer study, less accurate in picking up calcification, but is more widely used these days because there's no radiation. So I think there's an issue between safety and cost. So CT scans are cheaper but less safe. MRI is safer but more expensive, and it takes a longer time to perform. Generally longer waiting lists for most hospitals as well for MRI compared to CT scans. But when it comes to looking at it from a clinician perspective, MRI has some dedicated sequences that can be requested. So MRI is not just like a X-ray. MRI has lots of protocols, and there are protocols that are designed to pick up mineralization. And if we are using that protocol, MRI is very sensitive and specific. But the problem is this is variable across different parts of the world. Whereas CT scan is a standard X-ray using technology, which will definitely pick up calcification. So to answer the long question in short, yes, CT scan is better than MRI in most cases, unless you're using sequences that are designed to pick up calcium. And if you look at the cost and radiation exposure as a consideration as well, is because this will involve radiation. You can't have too many CT scans in your life, whereas you can have a number of MRIs in your life without any known side effects, at least. Yeah.
Okay, thank you. I've got a question here on why are some patients with large calcifications still symptom-free? Or is it that these people are just younger and not yet been affected?
Dineke, you want to take that?
Yes, we can do it together because we have the same experience probably, but the difficulty is that we indeed have patients with big amounts of calcifications who are quite good without symptoms or only mild symptoms, and the other way around. So that's still a bit complex, but in general, it's if you have more calcification, I showed a slide earlier on, if you have more calcification, then you have more risk of symptoms, but you have exceptions to that.
I completely support that. And I think it's also, when you ask about future, the answer is we don't know yet. Because if they're asymptomatic as of now, will they always be asymptomatic? Is something we don't know. Because unfortunately, most of the gene studies that have found these genes and all the studies on PFBC that I know, none of them have long-term follow-ups. So we really don't know, even from our clinic settings, we don't know what's going to happen to these patients later on when we see them in the clinic. And I think from the clinical perspective, it's impossible to say that because there is no evidence. We don't know whether they're more likely to get dementia later. We don't know whether they're more likely to get Parkinson's later. But again, these are the questions that have been asked recently, much more than they were in the past. And we are looking at some of these studies as well to see if there was a higher incidence of brain calcification in people with dementia, for example. Just a sort of like saying that later on, is it likely that they will get more problems? We don't have the answer to that yet.
And so thinking about this question, next question's about trying to mitigate potential mineral imbalances. Should somebody take calcium or phosphate or other vitamins to try and help prevent FARS or the progression of FARS? Is there any evidence to show that it helps?
I think Dineke is interested in that.
No, there's no evidence for that. No. So it's quite difficult because sometimes we have a patient with osteoporosis, for example, and then you want to give them supplements like calcium, but it's a little bit it's a little bit strange if you give calcium in people who already have too much calcium in their brain, but still we do it. But we don't have any evidence how to treat patients with FARS concerning supplements in the context of normal supplements or in the context when they have osteoporosis. There's no evidence at all for this.
Well, I will just add to that. I think what is very important to understand, and I've tried to do that with my talk as well, is these imbalances in calcium and phosphate in the brain are not reflective of what's happening in the rest of the body. They are very specific to gene mutations and problems with the phosphate channels in the brain, in that area of the brain, which is around the blood-brain barrier. So I think it's very important to understand whatever we do for the rest of the body might not translate into changing the calcium and phosphate levels in the brain and the fluid around the brain. So that's important to emphasize.
Yeah, thank you. Well, there's a few questions here regarding the eligibility criteria for the calcified study. And so just for absolute clarity, who is eligible in terms of nationality able to participate in the calcified study? And if there are restrictions on that, do you see another study in the future that could be broader?
Yes, in the Netherlands, the restriction is, I already summed up the exclusion criteria. So we don't include children, for example, or pregnant women or that kind of groups. In the Netherlands, we include Dutch-speaking patients. So if they cannot speak Dutch, then we have a problem because we cannot measure our main outcome properly. And for the German patients, we have German test and a German psychologist. And the Belgian patients, we only include them if they can speak Dutch. So the French part cannot be included, unfortunately. And Amit can tell for the UK, but I think that will be the same if they can speak English.
They have to consent in English.
Yeah.
But people in UK can, I mean, we're still a few steps off that. I mean, we're just waiting for the final ethics approval. We've had a few iterations. We should be hoping to start in spring, like Dineke mentioned. And eligibility criteria are the same. It's the same study. We're just a site. So Dineke is still leading on that study. And she's still got control of all the results that come out later as well. So it's just about, we are just a site to help patients in UK take part in this study. And when you talk about future or spreading that out, I don't think there's any plans for this study, as far as I'm correct. I mean, Dineke, correct me if I'm wrong, because this is if we find, let's say, a positive result from this, the idea would be to expand it to further. But if the results are not that supportive, then why would you? Because this will answer the question that we have: is this effective or is it not effective? And if it is effective, then we should work on the legislation to get it available all across the world. Doesn't matter if you live in US or anywhere else in the world, because if it is effective, then it's effective for every patient. If it is not effective, then you don't want to take the drug, and that's fine. Then we move on from there. That's the truth of all clinical studies: is you only need a certain number and a certain way to do it to prove whether this works or not. And if it does work, yes, it can be extended. And I think if the data is the data that come out of this will be quite robust, I think would be enough to convince. Because it's a repurposing drug, I think that should be enough to convince people to start using it. And if it is not going to work, which we can't find out till we complete the study, if it's not going to work, then you don't want to take that drug. So that's simple as that.
So I think just to add clarity for anybody on the call, currently this study is open to people in the Netherlands, Belgium, Germany, and the UK. I just mentioned this here, Fahr Beyond will in the future be conducting a survey of all people with FARS, and so that will be really useful. It might be research in a slightly different format, but it will be really useful to gain even more insight into the community. So the next question is one around the differences between approaches in supporting people with the disease. So how would you, if at all, support children with FARS versus, say, an adult with FARS? I know, Amit, you've been working in this space a bit.
So there are, I mean, one of the things to say here is we've used the phrase a few times now, rare movement disorders. And there is a group of conditions called ultra rare. So depending on if you're looking at individual genetic causes for PFBC, we're looking at something like an ultra rare, like 1 in a million kind of prevalence. So there are not going to be too many people across the world even to be able to sort of say that there will be specialized services available to each one of them all over the world. But usually they will be seen by pediatric neurologists where they are available. And the general principles that I highlighted in the first slide of my talk was what are the symptoms that patients present with and what needs to be done. And every pediatric neurologist is able, and even a pediatrician most of the times, is able to deal with all the symptoms when it comes to symptom management. I'm not aware of anybody leading treatment trials for disease modification, which is a different strategy to symptom management in pediatrics as of now. And I think the numbers are relatively smaller for pediatric group, also because they're more likely to have what we call secondary brain calcification than to have primary brain calcification. I've not gone into the details of the syndromes, the childhood and infancy syndromes that don't come with brain calcification, which is not, that's why I tried to maintain what PFBC is and what FARS means, because there are many other names such as Aicardi-Gouttier syndrome, Cockayne syndrome, that are ascribed to children who have brain calcifications due to other problems. This is not related to the same condition. They're completely different conditions, although the effect can appear similar because there's calcification in the brain. But these children will have lots of other problems. So a pediatrician or a pediatric neurologist should be able to address most of the symptomatic treatment. And I'm not aware of any particular interest from a pediatric neurologist in PFBC yet, also because of the numbers being very small, and they generally present later in life, usually after teenage. But that's not a rule, that's just a sort of generalization in a way. There are children who have, and I've seen a couple who started very young, and I've seen a 16-year-old by exception in my clinic as well. But that is rare. That is usually if there's other family members that have already alerted us to the possibility of scanning someone young with some neurological symptoms, and then you pick up, yes, this person has got the same condition that's running in the family.
Okay, I think this will be the final question, and this is a really interesting question, actually. Are there areas of the globe where FARS is more prevalent, or is it just maybe that diagnosis identifies FARS more effectively?
Sorry, Adam, I missed that. Can you repeat that for me? I somehow lost connection there.
This question is, are there areas of the globe where the disease is more prevalent, or is it maybe that certain areas just are better at recognizing and diagnosing?
Okay. Dineke, you want to go for that, or should I? Yeah.
Yeah, I think we have the most data is coming from Europe, and especially from France, because we have colleagues over there who does a lot of studies in genetic populations. And now China is also appearing with more and more research, so probably there will be more information about prevalence also over there. But there are no studies comparing prevalences across Europe or in the US or in Asia, so we don't know. I think that's the answer. I don't know if Amit has another opinion on this.
No, exactly. So I was going to say that there's no studies that can tell us the exact prevalence, but when you say in terms of the centers which look after brain calcification, somehow there is a predisposition. And I see from the chat I was going through, I know there's lots of question and answers that we haven't answered yet, but I'm sure you'll follow that up and you'll get back to them. But the idea is that there's lots of the audience today from US and Canada as well. And there's lots of questions about that. And interestingly, there are some centers in US and Canada that have experts who can still treat very much as we do brain calcification, but they cannot, I mean, they're not dedicated services as far as I'm aware. But somebody mentioned something in Mexico. I'm not aware of it. Dineke, are you aware of somebody in Mexico doing that kind of a study? There's on the chat there, somebody mentioned. I think we have Brazilian colleagues, some friends that we have in Brazil that are very interested. And in fact, the first study that I quoted was from Brazil, the Elendronet one. So there's, I think it is very random at this moment, and it's the largest number of patients that I'm aware of is with Dineke at the moment, if I'm correct, in terms of having an active follow-up, having treatment, or having a follow-up kind of investigations. There's a large group in Italy I'm aware of, large group in China that I'm aware of. France, of course, our great friend who's, and it also goes to show most of the genes that we're talking about, where have they been found? How have they been found? It's all in Europe, which is very interesting, and a couple in China, which is like, why is that the case, right? It's not that it's more prevalent here. It is just that the interest levels amongst the neurologists doing these kinds of things has been very high. And I think we can say that UCL, they have identified quite a lot of genes in movement disorders and cognition all over around the world. And John Hardy, who's been given the Google Prize, was leading on the Alzheimer's genes as well. So I think there is a bias that we find genes in Europe more commonly than some other parts of the world. And that's why it has generated more interest in Europe in terms of treating these conditions as well. But that's not true for prevalence, and we don't have data on that. I'm quite sure there's lots of people who are neurologists at the moment who specialize in movement disorders, cognition, who can see patients in Canada and US with this condition very well and manage them exactly as what we do. But at the same time, if we can help in any way as far, from the interest groups, or if we can provide any inputs to them, if you want us to connect to any neurologists that you're seeing, more than happy to do that. And we can provide whatever we can on top of what they're doing already.
Yeah, thank you. I'm aware of time, so we've now come to the end of today's webinar. Just a big thank you to the panelists, and a big thank you to everybody who has joined us on the call today. We will, as I've said, publish a list of answers to any outstanding questions. If you'd like to get in contact or find out more about the study or Fahr Beyond, please do just reach out to us. So Fahr Beyond, www.farbeyond.org, and there'll be a range of resources there and a contact web form. And we've also got our online community in the form of a Facebook group. So please do stay in touch, and thank you for joining.